Good evening, everybody. Today is Sunday, October 16th, 2022. Today is a case list defense webinar. We'll be going until 10 o'clock tonight. With a show of hands, do you hear me? We have good audio. Just want to confirm. Okay, very good. Thank you. Before we start, anybody have any questions about anything? Okay, I don't see anybody have any questions. Does anybody want to be part of the hot seat? Hopefully, we can have a lot of people take different turns. If you have been in the hot seat for the last 2 or 3 webinars, can you keep those hands down? And then if nobody else is raising their hands, then we'll open it up to everybody. So I see Ryan, I'm heading in that direction. It says you're self-muted.
Oh,
Can you
great.
hear me?
Can you hear me now?
Yeah. Hi, how you
Awesome,
doing?
thank you. Doing well, how are you?
Awesome, we're hanging in there. Are you a generalist or subspecialist?
Subspecialist. I'm a GYN oncology fellow.
All right, so OB, right? That's what you want?
Absolutely.
You have a specific case you're worried about or a topic? What are you looking for?
No, not necessarily. Just kind of just whatever comes your way.
So topic is good? All
Yeah,
righty.
yeah, let's do OB, definitely.
All right. So what are contraindications to a VBAC?
Contraindications to a VBAC are prior classical or T cesarean section. VBAC. Placenta, known placenta accreta, obviously placenta previa, or any abnormal placentation, vasoprevia. Any contraindication to a vaginal delivery as well, active HSV of the vulvovaginal region at time of vaginal delivery.
Anything else?
I'm sure there are more. I'm sure I knew of them. I'm trying to think of more. Not that I could think of at this time.
Think a little harder.
Yeah. So previous more than 2 prior C-sections in the past. A previous uterine rupture.
Anything else?
Any signs of fetal distress, any signs of current uterine rupture. I'm sure there are more too. I just can't think at this time. Yep.
Now, can you discuss for me an overview of how you would evaluate a patient to see if it's a candidate for a TOLAC?
Yeah, absolutely. So definitely it would be shared decision making, discuss and counsel the patients on pros and cons and benefits. Things to consider are future pregnancy goals. Does she desire more children after the current pregnancy? That could definitely weigh into the factor. As far as candidates, so previous C-section, the reason for the previous C-section, was it due to time of intrapartum factors or labor factors? Was it maternal indication versus fetal indication? Type of cesarean, whether it was a low transverse versus a classical incision or other incisions on the uterus. Other things to think about is maternal BMI, things that could increase her risk of a successful VBAC, such as maternal BMI, pelvimetry.
Can you give me an overview of your pelvimetry?
Yeah, so the 4 I know are gynecoid, which is
that's different. That's different types of pelvises. Pelvimetry is something very specific. But if you want to tell me about the different pelvises, go ahead.
Yeah, so no, gynecoid is the most common, and the most likely to have a successful vaginal delivery. Others are anthropoid, which commonly presents, or more commonly you see with occiput posterior deliveries. I know you have platypoid, which is usually it's a little flatter, where you can see more of a transverse lie for the fetus. And anthropoid, gynecoid. There's one other one I forget the name of.
So tell me about pivometry.
As far as
You brought it up.
yeah, I can't really think of in I guess what regards are you referring to? Just in general?
Something in your crevice of your brain brought that up. So what can you tell me about pivometry? What is the point of pivometry? Let's start there.
I guess to assess the size of the women's pelvis, to assess whether her chances or predictability of having a vaginal delivery or not.
And do you know any measurements you're looking for?
As far as I know, first you look for the sacral promontory, and that could tell you more of like an adequate pelvis versus not. I know there's a diagonal conjugate. I don't know the exact measurements that would make the conjugate adequate or not. I knew at some point. I definitely have to look that back over.
So what else would you do to evaluate the patient to see if she qualifies or is a good candidate for a VBAC or TOLAC?
So you could also do Bishop score and see the, you could see as far as the cervix, basically if her chances of having, or I guess the predictability of having a successful vaginal delivery.
Let's hold for a second. So
yep.
When you see a patient, she shows up for her first prenatal care visit at 10 weeks, and she's had a previous C-section, and you're going to start talking about Bishop score. So you have to assess the patient, see if she's even a candidate to even go to that point. See
Got it. Sorry. Yeah. I was thinking more of intrapartum.
As if the patient, what you have to do is act like the patient's right in front of you. For her first visit, is how do you know she's a good candidate for a VBAC? And then once she's a good candidate, then you move on. Are we going to be successful? Hopefully, you see the difference. If she's had a previous uterine rupture, she's not a candidate.
Oh, definitely. Yeah. So
you don't even have to discuss the different options. You're done. You're having a repeat C-section.
Definitely.
And earlier than 37 weeks for sure. But continue. I'm sorry.
Yeah, no. So if I see her at 10 weeks, assessing her chances, once again, it would be the reason for the previous C-section, and the type of C-section, and maternal factors that weigh into it as well, BMI, race, ethnicity, and shared decision making, whether whether she would desire even to have a trial labor after cesarean versus just opting to have a repeat cesarean. Other things.
Yeah, go ahead.
Previous vaginal deliveries as well could also be a factor.
What is the risk of uterine rupture with a classical incision?
So I know at baseline with a low transverse, it's less than 2%. So it's definitely higher with the classical. Probably guess anywhere from 5 to 10%.
What are signs of uterine rupture?
Loss of fetal station, fetal bradycardia, change in contraction pattern. I know it's less likely, but you could see vaginal bleeding as well. Maternal pain.
Anything else?
I guess also lower likelihood of seeing like a fetal part in the abdomen when you do an exam, or like feeling when you do an abdominal exam, you could see more prominent fetal parts. Other than those, none that I could think of.
Okay, well, we're going to stop there. What'd you think? This is the first time you've been on the hot seat?
Yeah, that was the first time. This was very tough. This was no, that's great though. I think it was obviously I still have a lot more to go over and reviewing things I knew years ago.
For sure.
But no, it's definitely, I think when you're thinking of things outside the hot seat, I think things come to you a bit quicker. So I think when you're on the hot seat, it's a skill to be put on the spot and think of things that.
And the thing is, just looking, because I always check who's been on the hot seat. So I haven't seen your name recently. So that's why I'm like, I don't think he's been on the hot seat. And it's fine if the same people want to be on the hot seat. But the key here, what you do in your brain is not the same as what you say.
Yes, yeah,
I mean,
that's key.
please never say pivometry unless you're really good at it and you want to discuss it.
Yeah, should not have said that.
You got your obstetrical conjugate, your diagonal conjugate, that's -2, and that gives you the obstetrical conjugate. I believe it has to be greater than 10.5 centimeters. I'd have to review that. Maybe one day I'll do a structured case on pivometry, and I'm sure the person who's getting it will just hit their head against the table. But that's when you get more practice verbalizing things, you edit what you say.
Yeah, keep it in your
And that's
wheelhouse.
key,
Yeah.
because what they do is you say something that you may not feel comfortable discussing, and you're saying it, well, pivometry, and okay, can you discuss pivometry for me?
Definitely.
So
yeah.
let me see if I can give you some key pointers. So what are contraindications to a VBAC? Simply, any contraindication to a vaginal delivery, such as a previa. Stop it there. Don't give any more information. Because nobody in their right mind is going to deliver a previa vaginally. You could say accreta also, but then they could start asking you about accreta, right? The different accreta spectrum, increta, percreta, whatever. Previa, I don't know much you can do. What's a previa? Well, the placenta's in front of the cervix. That's straightforward. Nobody's going to deliver a previa vaginally. You've brought up HSV, which is true. I've had people bring up HIV, malpresentation, breach. Well, now we can start talking about breach, because some people can, few and far between, but some people do deliver breaches vaginally. HIV, some patients that have HIV deliver vaginally. So now you're opening the door to questions that you may not feel comfortable discussing. And remember, who's testing the OB sections? MFMs, and they're going to know a lot more. We're just generalists.
Yes.
So, and I would stop there at previa. Do not give any more information.
Got it. Or
more than 2
can I just say then, would it even then be better just to say any contraindication outside of the TOLAC that would be a contraindication to vaginal delivery, and just leave it at that, so you don't open the door? Or is it better to give one or two examples?
I think giving a previa, it's kind of understood nobody's going to do a vaginal previa.
Yeah.
So I think that to me is the simplest one.
Got it. Okay.
Oh, she has a android. The one you forgot was android, I believe. Android pelvis, which is more the male pelvis. Okay, now you really opened the door to, okay, what's the measurements and pivometry of an android pelvis? So more than 2 C-sections, any classical or transmyometrial incision, or you do not have the facility that can do a C-section in the time required, and nobody's in-house, that type of, so smaller hospitals do not have that capability. Okay, in regards to how you evaluate a patient, or to see if she's a candidate for a VBAC, like when you go for your first prenatal care visit or subsequent, to a couple of visits, you should be bringing that up to the patient. And there's the VBAC calculator, but I've actually tried to make like really bad patients on the calculator, and they always come up to be about 60+%. So usually, I guess everybody gets an option, but it's nice to bring up that VBAC calculator. I can obtain her op report to see if she has a 2-layer closure, and it's a low segment transverse. Some people go into the discussion that, of the 3 of a vaginal delivery failed TOLAC and repeat elective C-section, the simplest one with the less complication would be the elective C-section in comparison, for lack of a better word, than the failed trial of labor. Well, of course, everybody would like to do it vaginally if possible. You know, and what are her desires? And I liked how you started there. And then when you say anything else, or, I mean, doesn't mean you're wrong. They just want to psych you out. Sometimes you are, you know, you need some more information. Okay. The risk of a uterine rupture with a classical is 10 to 15%. Uterine rupture with a low segment transverse is less than 1%. It is 0.5%. Signs of uterine rupture is vaginal bleeding, loss of station. I would just say non-reassuring fetal heart rate tracing. Don't bring up bradycardia because you don't know. It may not.
Definitely.
I mean, I've seen a uterine rupture where literally it just becomes agonal.
Got it.
I wouldn't bring that either, but just say non-reassuring fetal heart rate. And if I wanted to discuss category 3 tracing with you, they'll lead you in that direction. And lower abdominal pain, kind of not what you were expecting or what's going on that particular time in the labor. Maybe the patient has an epidural and she starts yelling in pain. You got to be worried.
Got it.
Okay. Any other questions?
No, that was
Well,
excellent.
good job for the first one.
Thank you.
And I definitely would know about VBAC because I'm sure that will come up somewhere.
Definitely. Well, thank you.
Okay. Yeah, no worries. Good job.
Appreciate it.
Yep. All right. I'm just seeing anybody who has not gone in the last 2 or 3 webinars. I'm just looking down the line. I see people that have gone. Okay. I see Laurel. She has not gone because she's not on the list that I have. Says you're self-muted, Laurel.
Hi.
You there?
Yep. I'm
Hi.
here.
How you doing?
Good. How are you?
I'm correct. You haven't been on for some time.
Yeah, that's correct.
All righty. Remind me, generalist, correct?
Yes, generalist.
Okay. What are you looking for? Something from your case list? Yeah, you have a case?
Do I have a case, an OB case?
Okay, you do. Okay, hold on. Let me look for it. So my screen is black, so I'm gonna be looking for it.
It'd be OB case, and it's number 47.
Give me a second. Let me look for it for you. I mean, you had a bad outcome or something? I haven't looked at it yet.
It ended up being an okay outcome. It was just complicated, I guess. I mean, it wasn't a good outcome, but
Let's go into it. You have a big list. And you gotta know all the freaking patients, right? Do you want to present the case? There, you should be seeing the screen now.
yeah, 47. Yeah, so this patient is a 33-year-old G1P0. She was brought in for induction at 39 and 6 weeks for GDMA2 on insulin initially. And then once she came in for induction, before anything was even started, she actually was noted to have severe range blood pressures and was given 20 of IV Medalol. Blood pressures were stabilized at that point, but she was diagnosed with severe preeclampsia, started on IV magnesium.
Can I interject here a second?
Yeah.
This patient was an A2 diabetic. What was she on for her diabetes?
She was on NPH at night.
So patient on insulin, she was getting twice weekly antenatal testing, correct?
She was.
Why was she delivered after her due date?
She was brought in prior to 40 weeks, however, it was after 39 weeks.
So why not sooner?
It was not I didn't manage the patient. I know that if I had known her in her prenatal care, I would have brought her in prior to 39 weeks, or probably around 39 weeks.
Did she
But
have good glycemic control?
she had great, yeah, she had good glycemic control. I
Okay.
think she a little bit. I mean, I think, yeah.
Okay, so continue.
But
So if she was in your hands, you would have induced her sooner.
probably sooner, yes.
Okay, continue.
I think 39 weeks would have been ideal. She was on quite a bit of insulin at night, but it was well controlled. So so she was started on magnesium. Her blood pressures remained controlled. We were able. Her induction was started. She was closed. Did not have a favorable cervix. Received Cervidil, and after 12 hours, it was removed, and she actually was able to receive pitocin at that point forward.
What was her exam after the Cervidil was removed?
She was 260 minus 3.
Okay.
And so she was given pitocin at that point. She dilated to 4 centimeters. AROM was performed at that point. Pitocin was continued. And she continued to dilate. She had slow progression at this point, though, actually. So from 4 centimeters to 8 centimeters, where she arrested basically the time of rupture. She went 18 hours essentially. And at that point, she actually developed choreo. She had a persistent fever. The first one was 39. She received Tylenol. She also
So what antibiotics did you start her on for the chorioamnionitis?
She was started on AMP and Gent. She was given
So what
2
is the what was the AMP treating?
The AMP was treating gram-positive bacteria.
And what was the Gent treating?
The Gent treated gram-negative and some anaerobes.
And what was the dosing of the meds?
She got ampicillin 2 grams IV Q6, and she received Gent 5 mg per kg Q24.
Okay, continue.
So when I came on and actually took part in her care.
How long was, so from the start of her induction
Yeah.
to when you showed up, how long had it been?
Probably, oh gosh, at least 24 hours. At least 24 hours. She had been ruptured.
It wasn't more, because it says that
Yeah.
she was diagnosed with preeclampsia at 39 and 6, yet she delivered at 40 and 2.
Right. It was probably past 20. I mean, it was probably on almost close to 48 hours at that point.
Okay.
Because I came on the day she delivered. And she did deliver, I mean, 40 and 2, she delivered like in the middle of the night.
Of course.
Kind of thing. Yeah. So when I came on, she was just getting diagnosed with choreo, and she did make it to active labor. However, basically she made it to 8 centimeters. She had an IUPC inserted. She'd been on Pitocin for over 24 hours at this point. She had received a Pitocin, well, she'd been on Pitocin for over 24 hours. And she was having adequate contractions, 200 Montevideo units over 10-minute intervals. And at that point, she remained unchanged for, I think, about over 4 hours at that point. And so the diagnosis of arrest of dilation was made. And so at this point, we made the decision to do a C-section.
I made the decision.
I made the decision to do a C-section, sorry. And during the C-section, it was complicated by uterine atony. She lost a little under 1,500 cc's in the OR. She received 40 units of Pitocin IV. She received Hemabate.
What's the dosing there?
25 micrograms, 250 micrograms. Yes.
What's the route of administration?
She received that IM. And
And what's the frequency?
that can be given every 15 to 20 minutes up to 8 doses.
And what's a contraindication?
Asthma, reactive airway disease would be one.
Okay. Continue.
So she did receive that, and intraoperatively her uterus, the tone improved. And I was able to get control of the bleeding, finish the C-section. Afterwards, her uterus, like before she left the operating room, her uterus still felt firm. I did also place 1,000 milligrams of misoprostol rectally before we left the OR, just to provide additional uterotonic.
What's the frequency of that?
1,000 milligrams. Q24 hours.
And what's a contraindication?
Rectally, I mean, potentially it could affect somebody who has reactive airway disease as well. But
Okay,
that would
continue.
think of. She did well, and then about an hour to being in the PACU, I received a call from the nurse that she had noticed she was beginning to actively bleed in the PACU. So I immediately went
Let me
over
interject here a second. So she lost 1,500 in your case.
about 1,500, yeah.
Did you do any coags? Any CBC?
She had a CBC prior to the C-section of 14.5. And I did not immediately, because she was going to be due for morning labs around 4 a.m. that day. So nothing had been ordered yet this time yet.
Okay.
And she started.
So they called you to the PACU?
She called me to evaluate her, and I went in, and she was actively bleeding. So I called for assistance. I called just for additional nursing staff. I made sure she'd already had 2 IVs in place from her C-section. She did still have the magnesium running. The plan was for that to continue 24 hours postpartum. And so
Did you hold that, or you continued it?
at this point, we paused it
Okay.
during the evaluation. I did. I had them continue giving hemabate. I started tranexamic acid, and I was able to do an internal exam, actually, because she was still somewhat comfortable
With the spinal or epidural?
Yeah, with her spinal. So I was able to do internal exam, and about when I got there, she had probably 500 around her, and coming out as I was able to do the first exam. And as she was continuing to bleed, it felt like she was intermittently becoming atonic and having tone. So we made the plan to move back to the operating room to continue taking care of her. I was able to continue to remove clots and massage her uterus. We were still giving hemabate. She received 4 doses. Her blood, at this point, we did get labs, and I did call for what we have as the emergency. The thing prior to massive transfusion protocol is the emergency, our emergency cooler, which has 2, I think 4 units of packed blood cells, 2 units of FFP, and it's kind of the first step in the massive transfusion protocol. It doesn't have platelets, and once you move through that, then you would initiate the next stage of the true massive transfusion protocol, which would include platelets. So we started hanging blood. She also received a unit of FFP. Labs were drawn, and her hemoglobin was at 11. Her coags were above 200, and her platelets were above 150 at that point.
And how much has she had lost at that point?
At that point, she was at, when we were in the OR, we had the labs drawn. She had probably lost the initial 1,500 in the OR, and then probably it was over 500 at that point. So it seemed like the bleeding was slowing down as we neared an extra 1,000. And I was at that point, I had my partner in the room. We had anesthesia and additional staff, and I made the decision to place the Bakri balloon because even though it was slowing down, it was still continuing. So I placed the Bakri balloon. I put about 300 cc's in the balloon. We used an ultrasound to place it, as we were also looking to make sure there was nothing retained. Nothing was retained. And her uterus felt like intact at the hysterotomy site and everything. So the Bakri was placed, and at this point her bleeding actually had stabilized. The additional, this was probably like an additional liter, and the additional 500 after that was like kind of during placement and after the Bakri was placed, while we were watching her down in the operating room.
So she went to the ICU because of the amount of bleeding she had?
She went to the ICU, yes, for the amount of bleeding she had, and
then how much blood had she received to that point when she was taken to the ICU?
blood and 1 unit of FFP.
You broke up. Say again.
2 units of packed red blood cells and 1 unit of FFP.
One.
And her blood pressures, they were on the higher side because she was a preeclamptic. However, she did become hypotensive and tachycardic, obviously, during this exam, but she was always alert and oriented and responsive.
So what happened with this E. coli sepsis?
Yeah, so she went to the ICU. They actually did not give her any more blood products. Her hemoglobin kind of leveled out at 10.2 after the 2 units of blood, and it stayed stable there. The Bakri balloon stayed in for 24 hours and was slowly removed. In terms of the sepsis, so anytime she had ended up having another fever during this whole thing, and it was up to 39. So
and she got blood cultures?
She got blood cultures and she got a lactic acid drawn. However, this was after a C-section and during the hemorrhage, and it was elevated to 2.2. So, and also her platelets did end up going down below 150. And obviously she had periods of being hypotensive during the.
And what was she continuing on for antibiotics or started?
She was on
post-op
for her to get Genitofemeroal, at least another dose, but
you broke up. She was on what?
She was good. Plan was for her to get Gent and Clinda afterwards.
Why not amp Gent and Clinda?
The initial plan was Gent and Clinda, and then she had to
but
add.
She had core. So how do you treat choreo? Amp and Gent.
Amp and Gent.
Right.
Amp and Gent.
So she delivered the baby. She still has the choreo.
Mm-hmm.
So why didn't you continue the amp and Gent?
I often will add if people
how do you treat endometritis?
Gen Clinda.
She had choreo or she had endometritis? I'm not saying what you did was wrong. I'm just
choreo. She had choreo, yeah.
And what would cover the E. coli of all the medications that we discussed?
The Gent and the Clinda would.
I would think the Gent would be better.
Yeah, the Gent.
I'm not an expert. Did ID see her?
So yeah, so when
what did they say?
So she was actually they were like, I don't believe she's actually septic. They felt like it was E. coli bacteremia. But however, because there was no sign of true organ dysfunction, it was more just a little bit confounded by the hemorrhage and the C-section and the.
So I think you should have written in your presentation E. coli bacteremia instead of sepsis.
That was it. So so this patient, I obviously went home that day, and then the diagnosis of the E. coli kind of came afterwards. And when I looked through my partner's notes, they wrote sepsis. However, when I was looking a little bit more into the case, I saw the actual IDs note where they wrote this actually is bacteremia. That's why it's complicated. But it was just it was an unclear picture because of all of the factors with the hemorrhage and the E. coli in the blood. They felt like it was probably more of a bacteremia. So
Go ahead.
She was treated with Zosyn, actually.
They always start everybody on Zosyn.
Right. So she was put on Zoshin, and then she was able to go home. She got Zoshin for the 40.
But was there any resistance to the
No.
E. coli? It was
And
sensitive to everything.
so she ended up going home on Augmentin for 10 days afterwards, and she followed up in the office within a few days after her discharge, and her bleeding had ceased. It was very minimal. She had minimal loci, and she had no signs of endometritis at that point.
So your concern is just the E. coli sepsis. Well, I would
it-
know very well the definition of sepsis, what meets the
Yeah.
criteria, and how she did not meet the criteria, and
Right.
then say that it was not present. I could have presented it with a better terminology. I think E. coli bacteremia would have been better. She was not as sick to be septic.
I also was worried about the large EBL. It was just, I think
It was
it
due to
wasn't,
acne. Nothing you could
wasn't
do
a,
about it.
yeah, it was, I wasn't sure if I like overcalled it or anything, but
I mean, it's possible. I mean, what I found more interesting is why she got delivered so late. That's
yeah,
what stood out to me. That and arrest of dilation is not really a term that's really, ACOG doesn't like that term. It'd be more arrest of the active phase or
Yeah.
arrest of the first stage. Some people say that as well.
okay.
I usually say arrest of the active phase, but you presented that well in the sense that she had her IUPC, she had her multividal units, and so on and so forth.
Okay. Yeah.
Does that make you feel any better?
I-
Oh,
it does really.
misoprostol has no contraindication,
No
unless maybe
contraindication.
you have an allergy to misoprostol or something like that.
Okay.
Okay, and you didn't give her the methogen because she was
was
preeclamptic.
right.
Okay.
Okay. Thank you.
No, yeah, I mean, she had a good baby. She's good. It all worked out.
Yes.
So I
it
think
does.
you have to just be honest and say, you got to be honest and say, if they question it, that I would not have induced her at that point. I would have induced her a little bit sooner and be ready to discuss when you would have done it.
Right.
And then the word sepsis. But
Right.
I'd be really well versed on the definition of sepsis.
Right. Yeah.
Okay.
Thank you.
Okay, very good. All righty. Anybody else want to be part of the hot seat? Stephanie, I'm going in your direction, and it's Stephanie D. How are you doing, Stephanie?
I'm good. How are you?
We're hanging in there. Are you a generalist or subspecialist?
Generalist.
And do you have a specific case
I don't.
or a
Nope,
topic
but
is fine?
anything. Yep.
We've done OB, right?
Mm-hmm.
For GYN?
Sure.
Office.
Uh,
What you looking for?
let's do GYN.
GYN. So during a hysterectomy, can you tell me the most common areas or sites where the ureter can be injured?
Uh, yes. So, the securing your uterine arteries, and closing your vaginal cuff, and then if you're taking the ovaries as well with the IP ligament.
Anywhere else?
Those are the times that I'd be most concerned.
Can you tell me the pathway of the ureter?
Oh my gosh. Okay. So, yeah, so it's 30 centimeters long total. 15 of it is in the pelvis. So it comes in across the internal iliac, descends along the pelvic sidewall posterior to the ovarian fossa, goes from lateral to medial, crossing under the uterine artery, 1 to 2 centimeters from the cervix, then continues anteromedially, inserts on the bladder. I think
Where in the bladder?
at the trigone.
Now, if you were doing an abdominal hysterectomy, can you explain to me how you identify the ureter?
So in an abdominal hysterectomy, you would have good visualization. So you want to look for your ureter, of course, in the medial leaf of the broad ligament. I mean, you usually can actually just see it in that area with the peristalsis, but
Is there a
I'm not sure
specific
how.
area that you can kind of open and take a look at?
You can open near your I don't know how to explain that.
All right, so let's say you have a ureteral injury at the IP. How would that be repaired?
Ureteral injury at the IP. So it would definitely be an area that you'd be concerned. Oh, actually, sorry. You want to make sure that the repair would not have the ureter on tension, but of course I don't do this myself, so I would try to call in colleagues, urology, to help me. I know they're not available, they're on vacation, but they can actually directly reconnect the ureter depending on the injury. If they're not available to come in, you can temporize it by having IR place a nephrostomy tube and repair later.
But let's say you find the injury during your case. You wouldn't have it repaired at that
Oh
time?
yes, I would try to have them take a look to repair it so they could do an end-to-end repair, I believe. Oh gosh, I can't remember the upper ones quite as well. I think if they needed to, no, those are the others. Well, I can't remember, I'm so sorry.
So what would be the name of the procedure that the urologist would be doing?
I literally just can't remember right now.
Okay, so let's say you have an injury, let's say at the uterine artery. How would you repair that?
When it's within 5 centimeters of the bladder, you could usually repair it with a ureteroneocystotomy. Let's see. Yeah, I think they would attempt to directly reimplant it into the bladder.
And let's say the repair's under tension. What would the urologist do?
To facilitate a repair without tension, they could either do the Bori flap or the psoas hitch.
And let's say there's a crush injury to the ureter. How would that be repaired?
I think that portion of the ureter would be removed to get viable tissue on the injured portions for repair. So if that significantly shortened it, you might have to do one of those procedures to take it off of tension. But if you had two ends that you could spatulate and close back together, it could be done that way as well.
So when you're doing, for example, a C-section, where usually would you damage the bladder?
Typically the dome of the bladder.
What about an abdominal hysterectomy?
Probably closer to the trigone.
What about a vaginal hysterectomy?
I'm not sure.
What's the first initial step you should do when you're doing a bladder injury repair?
You want to know whether it's near the trigone or if it's away, if it's in the dome of the bladder, because you want to know whether you need to be concerned about a concomitant ureteral injury.
Okay, let's stop there. I'm sorry, it was a bad one, huh?
Oh, it's very common, so I just need to get better at saying things and thinking
Exactly. Exactly. So usually they'll say at the IP, you could be injured, at the uterines, at the uterosacrals, and at the cuff angles.
of them.
I think you have to be specific and say cuff angles.
Okay.
So, for lack of a better description, when you transect the round ligament, I don't know if you've ever done this, you have kind of part of that filmy broad ligament tissue, right?
Mm-hmm.
And you can literally keep going down.
Okay. Mm-hmm.
It's kind of, kind of between the round and like the uterovarian ligament.
Yes.
You use your yanker and you flip the non-pickup part of your long pickups, and you kind of keep going down, going up and down, or anterior, posterior of to the patient, and you'll keep bringing that filmy tissue down, and you will find the ureter on the medial leaf of the broad ligament.
Okay.
That makes sense? You remember doing that?
Yes.
And if you do that there, it's very easy to identify the IP.
Okay.
And you could tell if it's very close to the ureter or not. And then that's how you can do a really good BSO, because you want to get as close, I think it's up to, as close to the side wall as possible in a risk-reducing BSO. Because I know some people will refer those patients to an oncologist, but if you can identify your ureter really well, you should be able to pull that off. I mean, she's had a lot of surgery or something, it might be more difficult, of course. A crush injury of the ureter, you insert a ureteral stent, to my understanding.
Okay.
Okay, so hopefully, if that crush opens up and you don't have that scarring. Thermal injury is going to be very different, and I don't think they're going to ask you about thermal injuries because you don't know what you need to transect. If you need to transect, you just don't know what will happen. So I don't think they'll go that route. Above the pelvic brim, it's a ureterostomy. Okay. And you perform it because you cannot mobilize the bladder. So you spatulate the ends of the ureter. You place 4 to 6 interrupted sutures of 4 chromic through the full thickness of the cut edge. Site of the anastomosis is drained. It can be performed regardless of location, provided no tension. Ureteric stents and bladder catheter in situ for 10 days.
Okay.
If the breach is less than 5 centimeters from the bladder, you would do a ureteral neocystotomy. You implant the ureter directly into the bladder. If the breach is more than 5 centimeters from the bladder, you need to do either a psoas hitch or a Biore flap. I think, I'm not a urogynecologist, but a psoas hitch is much easier because there is no blood, you don't have to worry about any blood supply. But to my understanding,
Oh, is that why they have those circles?
Yeah, like smart switches.
I don't know who's on the line here. I don't have anybody else. Stephanie, are you there?
Yes, I'm here. I heard it too.
I don't know. I don't see anybody with any everybody, you're the only one that's on the call, so I don't know who's talking.
I don't either. Okay.
I mean, maybe they're telling us the winning lottery numbers. That would be so nice. That's never gonna happen. But with the Biore flap, I believe you gotta retain the blood supply.
Okay.
To the flap. So, but I believe, I'm not a urogynecologist, that urologists prefer the Biore flap versus the psoas hitch.
Okay.
Okay, C-section dome. It depends where your damage is as you're trying to bring down the bladder in a abdominal hysterectomy. I would say if it's more like kind of the dome or behind the dome.
Okay.
you know, vaginal hysterectomy is the trigone. Think about it, because
Okay.
you're going backwards, right?
Yes. Yeah.
So if you get an injury of the bladder in a vaginal hysterectomy, you could be in trouble because you could have injured the trigone.
Okay.
Am I making sense?
Yes.
So did we go over all the questions? And you did good with the ureteral pathway.
All right.
So
Thank you.
questions. So I have a question here from Alyssa. What structure less than 5 centimeters above the UVG? The uterosacral. But the thing is, from my understanding, it is tough to do a good repair to the uterosacrals. Again, I'm not a urogynecologist. You could do a ureterostomy anywhere in the process of the pathway of the ureter, but you can't have tension on the repair. Would they ask us about trigone repair? This is from Janelle. You know, who knows? You know, I mean, I don't think so. That's not something that I know Exam Pro discusses in their texts, all the manuals that you guys have. I mean, but you definitely got a stent, you know. The key here is to identify, so when you repair it, you're not, you know, closing up the ureter because you're not paying attention to where the injury was. And hopefully that answers your question, Janelle and Alyssa. But the way I think of it, and I've talked to a urogynecologist about it, but then when I look at things in books, it may say different things, because when I've seen a psoas hitch, it's really high up. So I'm like, why can't they do that for an IP injury? But they prefer the ureterostomy. Again, we're seeing it as a perspective of OBGYNs. It's possible a urologist does it completely different. And then at anything greater than 5, I'm thinking more like the uterines. Lower than 5, your uterosacrals. But I've heard that it's much more difficult to do repairs down there because you're further into the pelvis. Again, I'm not a urogynecologist. And I do have a question from Jacqueline. Misoprostol contraindicated for cervical ripening in a history of C-section. I'm not quite sure what you mean by that, but you do not use misoprostol for any cervical ripening for any induction in a C-section. That is contraindicated. ACOG is very clear on that. So I don't know if that answers your question, Jacqueline. So hopefully that answers your question. When can you redose misoprostol? Oh, thank you, Alexandria. To my understanding, it's a one-time dose. However, I have talked to, this is to my understanding when we as obstetricians look at our texts, for lack of a better word. But I believe I was talking to a pharmacist a couple of weeks ago, and they were saying, maybe you can give it maybe 24 hours later. I'm like, that's not what we're trained to do. It's only a one-time dose and that's it, you're done. Okay. So I have can you repeat what the most likely site of bladder injury is by type of hysterectomy? So C-section would be your dome. Your abdominal hysterectomy, I would think more dome or kind of behind the dome. Now, if you're doing a vaginal hysterectomy, you're looking at things backwards, right? Or from below, right? So when you're trying to find that reflection, that you have to go in from the peritoneum and the bladder tissue, that's in the trigone. If you have an injury there, you may have injured the trigone. So very important to know where that area is. So Ruby's writing for induction less than 28 weeks. You're talking about misoprostol. I'm thinking that's what you're talking about. Ooh, like an IUFD. So you're talking about, Ruby? Wow. You know what I've done in the past is I would say no, because she's 3rd trimester. If you're less than 3rd trimester, I mean, you could definitely do it in the 2nd trimester, up to 28 weeks. Because usually I touch base because I know some pharmacies will not release it. Alexandria is saying ACOG says you can use it in the 2nd trimester IUFD less than 28 weeks. You know, but it's not like in the 2nd trimester, like a 16, 17 weeker where you can give her a lot more dose. You could still get a rupture, but you could give a higher dose. I wouldn't give that much of a high dose in that type of scenario. Now they're saying, could they ask you how to diagnose ureteral injuries intra-op? Well, Ruth, yeah, I would think so. And, you know, everybody does cystoscopies anyway. So that's how you diagnose it, right? You don't see the jets in the particular area that could be affected. You can use misoprost for second trimester loss even with a history of C-section, I believe. That is correct. Somebody typed that in. I'm thinking you guys were talking about, you know, somebody is being induced at 40 weeks. You wouldn't in that situation, okay? Does that answer everybody's questions? All right, cool. So I saw Annie had her hand up. I'm going in that direction. It says you're muted, Annie. Yeah,
Hi,
there you
can
are,
you hear
Annie.
me?
Yeah, awesome. How you doing?
I'm well. How are you?
Yeah, living the dream. What can I tell you?
Yeah.
Are you a specialist
No,
or
I'm a general.
generalist? Okay, do you have a specific case that concerned you? You want a topic? What you looking for?
Nope, anything.
Anything. Want to try office? We really haven't done office. Or not
Sure.
really. Oh, you don't sound excited with that.
I
You
have
want
to
to try
do it.
something? You have to
No,
do it?
yeah, I'll do it.
You sure?
Yeah.
All righty. So let's say a patient comes to your office and she's pregnant and she has a beta HCG of 3,500. How would you evaluate this patient?
So if a patient comes to me and they say they're pregnant, usually I confirm that they are pregnant. I find out if, if she has a beta HCG of 3,500, clearly she is pregnant. Find out what her last menstrual period was, if she has regular periods, what her menstrual history is, to see around what her gestational age should be. At 35, I'm sorry, was it 3,500 or 35,000? You should be able to see,
3,500, 3,500.
yeah, you should be able to see, an embryo at that cutoff. So, you could check a pelvic ultrasound to see if you identify an IUP or if you identify pregnancy elsewhere. Also,
So let's say, go ahead.
oh, sorry, you can go ahead.
No, go ahead.
I was just going to say also, anytime I have a patient with a new diagnosis of pregnancy, I go through their history, their pregnancy desires, if it's a desired pregnancy, if they want to continue the pregnancy, if they're on any medications that are teratogenic, make sure that they've been taking prenatals if it is a desired pregnancy, kind of go through all that. And if they don't have a documented IUP, making sure they don't have any signs of like ectopic pregnancy, pelvic pain, or vaginal bleeding, things like that. That kind of guides where I'm going next with whatever the patient's doing. Sorry, it's my dog.
So let's say you get your ultrasound. It shows no intrauterine process, no free fluid, no adnexal mass. What would you do?
I would, again, find out if this is a desired pregnancy. I would counsel the patient, let them know that that there wasn't a pregnancy location identified. At 3,500, typically you would see a pregnancy. However, if the patient has multiple gestation or something like that, then you wouldn't be able to necessarily see. So I'd have her come back for a repeat quant and repeat imaging. And also I'd want to know if the patient bleeding or having any like cramping, has she passed any tissue? Like, is this potentially a failed pregnancy?
So let's say you have her come back. When would you have her come back?
I would have her come back in 48 to 72 hours to check her quant to make sure it's rising appropriately.
So let's say she returns 48 hours later and her beta HCG is now 5,000. What would you do?
So I would have expected it to increase more than that. It should be closer to 7,000. So I would talk to the patient about that, say that it is rising, but it doesn't seem to be rising appropriately. And I would repeat imaging with another pelvic ultrasound.
The ultrasound shows the same exact thing as 48 hours before.
Well, at
I'm sorry?
5,000, at 5,000, you
Correct?
really should. At 5,000, you really should see something. But again, I would, counsel the patient this is likely a abnormal pregnancy, not likely to be a viable pregnancy. However, if the patient is strongly desiring pregnancy, I think it's reasonable to have her come back, but not give her false hope and say that she's likely to have an intrauterine pregnancy that will be successful, but it's not impossible either.
So when would you have her come back if she is a highly desired pregnancy?
At this point, as long as she's not having any concerning symptoms for like an ectopic and she's not having bleeding or cramping, anything of that, I'd probably have her come back in like a week because I really should see something by then.
So let me interject here. I'm gonna get away from examiner mode. So you're telling me she's possibly an ectopic. She has a beta HCG of 5,000, but you'll have her come back in a week. Is that really smart?
No.
So why'd you
But-
say it?
Well,
If she really wanted this pregnancy, you already told me we should see something. We're not seeing something, correct?
yes.
So you're thinking she's an ectopic, right?
Yeah.
You should follow her up in 48 hours
Yeah.
at the latest, not a week.
Yeah. I don't know why I said that.
Okay. So I'm gonna go back now to examiner mode. So she comes back because she really wants this pregnancy, and she has a beta HCG of 10,000.
And again, I do imaging and I'm assuming I don't see anything on the pelvic ultrasound again.
So she has, I don't know, she has this small little area in the right adnexa. They can't tell you really what it is, but it looks complex and it measures 4 centimeters.
And there's nothing in the uterus.
Nothing in the uterus.
Yeah, at that point, with a quant of 10,000, we followed it up. I would tell her it looks like we've got an ectopic pregnancy and we really should do something about it. So I would talk to her about medical versus surgical management of ectopic pregnancy.
And what would you tell her?
I would tell her that, because of her quant of 10,000 and how, how big that area is on the adnexa, I would recommend a surgical management.
You wouldn't offer medical?
I would discuss medical management with her, but it would not be my recommendation.
Why not?
Because I waited too long to manage it.
Do you know the different types of methotrexate regimens available?
Yeah, it would be 50. Usually I do the single dose regimen of 50 milligrams per meter squared or body surface area squared.
And what would be you said that's a single dose.
Mm-hmm.
What would be the other regimens?
I believe you give another dose on day 4, but you still, either way, you're following the patient's quant from day 1 and then day 4 and day 7 to make sure that you have an
So
appropriate drop.
you're confusing me a little bit. So let's go back to your single dose. Let's do the one that you're used to doing. You give them methotrexate day 1,
Mhm.
and then you're saying you do a beta on day 4, or you give another shot.
No, do
Give the
another beta,
beta, and then when would you follow after that?
day 7.
And what are you looking for?
A 15% drop from day 4 to day 7.
After day 7, how would you follow her up after that if she had the appropriate drop?
I would follow her with serial quants down to 0.
How often?
Every 48 to 72 hours.
Okay. I'm gonna take away, I'm getting out of examiner rule. It is every week. Okay, it's every
That's
week.
what it was.
And you want, say again?
So that's where the week was. in
Yep.
my head.
It's every week.
I swear I'm not
And-
stupid.
And I'm not saying you're stupid, because you're on the hot seat. And it's better to do it now than during the exam, because
Yeah.
it wouldn't go well. So it's better to learn your errors this way.
Yeah.
So everybody that's on the call, that's always on the call and never raises their hand, it's your prerogative, but it's very different when you're on the hot seat. Because you can't be stupid if you've made it this far in your career, right?
Yeah.
No. So it's the pressure. And it's better to have, don't look great here than failing the test. That's bad, right?
Yeah.
Because you got to disclose it. Like, have you ever failed a board certification exam? Oh, yes. And then you have to discuss why or how or whatever. So it's every week thereafter, and you still want that 50. The practice bulletin is not very clear. You want a 15% decrease from week to week to week till 0. Because I was a resident when they came up with this protocol, so it's 15%. So you said there was a 2-dose one. How would you do that one?
I'd have to look that up.
So you give it on day 1 and day 4,
Okay.
and then you would follow from day 7 to day 11, if I'm not
Okay.
mistaken. I may have to look that up because it's failing me. And then if you don't have, I gotta look it up. I'm blanking now. My apologies. I'm still thinking about the ureteral injuries. So you do your 2. So when would you use your 2-dose? Regimen.
The 2-dose regimen, I believe, is supposed to be a little better for patients who have a higher HCG, like more than 5,000.
And what else?
Oh, I said higher HCG, like more than
And anything
5,000.
else?
Or a embryo with cardiac activity, I think.
Anything else?
That's all I can think of right now.
Okay, so let me correct you for myself. So my apologies because I forgot. It's 50 milligrams per meter squared, IM, body surface area, day 1 and day 4. You check the HCG level on day 4 and day 7, and you want that greater than 15% decrease. If not, you administer another 50 milligrams per meter squared on day 7 and check the HCG on day 11. The decrease greater than 15%. Between day 7 and 11, you continue to monitor weekly till 0. If the decrease is less than 15%, you administer another methotrexate. You can go up to 4 doses on the 2-dose on day 11 and check the HCG on day 14. If the HCG does not decrease after 4 doses, you must consider surgery. It has a comparable risk of adverse effects as single-dose protocol. There was a statistically significant higher success rate for the 2-dose regimen in patients with initial HCG levels between 3,600 and 5,500. Non-statistically significant trend of greater success for the 2-dose regimen with an initial HCG of greater than 5,000. So what's a contraindication to methotrexate? Relative cardiac activity, elevated HCG, a greater than 4 centimeter mass. So don't forget the size of the mass. Right?
Mhm.
Make
And
sense?
like, yeah. And then
Uh-huh.
like liver disease or something too.
That's a little bit, those are absolute contraindications. So if anybody has, you know how you have to do all your blood work, check your
Mhm.
platelet count, your creatinine, your renal function, your liver, any of those are abnormal, she's not a candidate. That's it. Doesn't matter what regimen. Okay? She's not a candidate. Also, active pelvic ulcer disease, active respiratory disorder. Asthma is not included in that. I can give you the entire list if you'd like to hear it. This is straight from the practice bulletin. Absolute IUP, immunodeficiency, moderate to severe anemia, leukopenia, thrombocytopenia, sensitivity to methotrexate, active pulmonary disease, active pelvic ulcer disease, liver or renal dysfunction, breastfeeding, unstable patient, unable to follow up. Some people would consider decline to transfusion because you can come back in ruptured, right?
Yeah.
Okay. And then you have your multi-dose, and that's for like a corneal ectopic, cervical ectopic, corneal ectopic, cesarean section, scar ectopic. Okay.
Okay.
Question was that? Oh, I got some questions here. Hold on a second. Let's see what we got. You have any other questions, Annie? Well, good job. I mean, it's hard, right? This is the first time you've been on the hot seat.
I've been on once before. Actually, I had to do the course of the ureter with someone.
Oh, there you go. They never asked me that. Urban legend, right? Urban legend. Okay, would it be appropriate to send this patient after a beta of 5,000 to the ED to rule ectopic? I mean, you can, Andrea, but you should have the capability to do the ultrasound in your office and all that good stuff. So realistically, as an overview, Annie, hopefully you're listening. You're
Yeah.
not still on the call. Yeah. So you could do the conservative management, which I wouldn't, but if she really wanted this pregnancy, have her come back in another 48 hours and you tell her, if this doesn't, you don't see anything, that's it. She has to have treatment, and she has to understand the higher that beta gets, the less opportunity she has for a successful methotrexate treatment.
Yeah.
You could do a uterine aspiration or a DNC. While you're waiting for the path to come back, you could do a beta 12 to 24 hours after the procedure. You should see a decrease of 50% if it was an intrauterine process. Or you give her methotrexate. So those are the three options you could give the patient. If she said she doesn't want to, if you say she shows up at 3,500, the discriminatory zone is 3,500. It is recommended that at 3,500 you should be able to see something. However, what if it was a multiple gestation? ACOG's very clear in the practice bulletin. You should not treat a stable patient for a suspected ectopic without 2 beta HCGs with an inappropriate rise. Does that make sense?
Yeah.
Okay. So hopefully that answers your question, Andrea. Because I personally would have given her some type of treatment or discussed it. Okay. Because you can do the ultrasound in your, unless you don't feel comfortable with the ultrasounds you do at your office. Okay. So Jacqueline, it is day 7 to day 11. That's if you needed a repeat injection. Okay. For the 2 dose. And then there should be a 15 decline between day 7 and 11. If decline, then you do weekly. Correct. This is the methotrexate is given again on day 7, the single dose plus a second dose, but not the planned second dose regimen, if that makes sense. To me, it does. So, and once you start on one regimen, you can't flip to others. You stay in that regimen. Once you decide single or 2 dose, you stick with that one. You can't flip flop. So hopefully that makes sense. So can you discuss the recommended management for this case at the 3,500 and 5,000 HCG values? Personally, if nothing's seen on the ultrasound and her rise was inappropriate like that, I would highly suspect that she is an ectopic. So in my practice, I would have offered her methotrexate, and I would have offered her the 2-dose, because we're getting at a higher level that the methotrexate in a single dose may not work. And the practice bulletin says that they have some statistics. One says non-statistical significant, that it might be more beneficial when you're closer to 5,000. How would all the management change if this was not a desired? Would you still do serial quants? If it wasn't if I saw her at 3,500 and it wasn't a desired pregnancy, I would offer her methotrexate from the get-go, with the understanding that if it ended up, God forbid, being an IUP, she would have to terminate that pregnancy. And I've seen that happen. You can't change your mind, okay? Because you gave methotrexate. It's a major contraindication. But it makes it easier. Instead of following the patient, she's like, I really don't want this pregnancy. I'm like, it could be an ectopic. I'm not sure. Let's give you this medication and follow you along. And usually the patients go for it. So hopefully that answers your question, Alyssa. So when would it be appropriate to send her? And I'm thinking, if I got my 3,500 and my 5,000, Andrea, and I see nothing on the ultrasound, in my practice, some people would do a uterine aspiration. In my practice, I would send her for the methotrexate, and I would do it through my infusion center, because we have some places where you give your order, patient shows up and she'll get her shot, she'll get monitored, and then you'll see her on day 4 for her beta. Hopefully that makes sense, Andrea. Maybe I'm not making, am I missing something in your question? Just elaborate on the box here. So I have Jacqueline saying, don't forget the leucovorin. Yeah, I didn't discuss the multi-dose, but that is correct. So you give your weight-based in the sense of 1 milligram per kilogram of methotrexate on days 1, 3, 5, and 7, and then you have your rescue leucovorin on the even days. Okay. And of course, the leucovorin is to prevent the side effects. According to Jacqueline, she's saying she believes or the bone marrow suppression, but I think it's side effects in general because it's a much higher dose of methotrexate. Okay. So Alexander, are you saying that you feel that 35 to 5,000 was appropriate rise? Is that what you're saying? I see your point. I just made the numbers up, but realistically, at a level of 5,000, you should be seeing something. So if she's a desired pregnancy, I don't see anything wrong if she wants to get another beta HCG, with the understanding that the methotrexate may not be as effective. Maybe I should have given you a lower number. My apologies. So then Ryan's asking, could the examiners ask, what if the patient is non-compliant and presents for beta HCG measurements for single dose outside of 4 to 7? How would you evaluate her percent drop? That's a tough one, and I've seen that happen. I don't know what to tell you. You just have to play it by ear. I sometimes call my pharmacist to see what they recommend. That's a tough one. That's why if you have a non-compliant patient, then the methotrexate's not the way to go. It's to take her to the operating room. So I don't have an answer for you there, Ryan. Okay. So Maya's asking, yes, you could offer a DNC for confirmation. However, the practice bulletin is clear. It is not, there's a lot of debate among experts if that's required. Some people are of the belief that you should have definitive tissue non-diagnosis, because if it's an ectopic, you're not going to get chorionic villi before you give anybody methotrexate. And some people are not of the belief of that. So there is no stance on ACOG. ACOG says you can do either or. Okay, so that answers Andrea's question. Yes, if you calculate, you got me there, Alexandria. I mean, but realistically, at a level of 5,000, I mean, I once had a patient, believe it or not, she kept doubling. We followed her for 2 weeks. It was appropriate. And then finally you saw the baby. She did not follow the book. And, you know, she felt fine. There was no issues. So for the purposes of this exam, I think I just made this number off the top of my head. It wasn't the double. So I should have made it a lower number, you know? In the real world, if she's appropriate rising, then you should continue monitoring, and hopefully the baby pops up. But you could say, I'm still a little bit concerned. I would prefer a higher level of rise, because usually if the pregnancy is going well, it's going to be a much higher rise. For beta of greater than 3,000, don't you only expect a rise of 30%? So 5,000 would be appropriate. I'm sorry, Karine, I should have given a different number. So my apologies, because I was just doing double in my mind. But Alexandria's point, it should be high enough to see something. That's correct. Again, so that's why you bring the patient into the conversation if this is a desired pregnancy or not. Okay. So hopefully I could have given a lower number. So my apologies there. I was just doubling in my mind. And then Andrew's saying, usually what we do in our office is we send them to the ER to have an official sono along with the beta. Then we make a decision to give methotrexate or do a suction DSC at the time. Okay, cool. That's good. So hopefully that answers everybody's question. So my apologies. I could have picked I guess a lower number. I was just doing double in my mind. So my apologies there. Okay. Christine, I see you have your hand up. I'm going in your direction. Okay. So hopefully that's answered everybody's questions. You there, Christine?
Yep, I'm here, and I apologize if you hear a screaming baby.
No worries. Generalist or subspecialist?
That's special.
Okay, what do you do?
GYN oncology.
GYN oncology. The leucovorin, that's to just prevent the side effects in general, correct? Not necessarily just bone marrow suppression. That's just one of the side effects, right?
Yeah, yeah.
Anything else specific that the leucovorin does?
Not really. I mean, it's just sort of to help with the folate. So, yeah, no.
Okay, cool. So I'm assuming you're looking for OB or no?
Either OB or office.
Do you have a specific case? I should ask you that first.
No, just a
No
topic's fine.
specific case. Can you discuss the growth phase of hair for me?
So the growth phase of hair, no, I'll have to look that up, to be honest.
So what is the mechanism of action of OCPs in regards to hirsutism?
So for the mechanism of action for OCPs with hirsutism, it is decreasing your androgens, which can act through the sex hormone globulin.
What other medications can you use for the treatment of hirsutism?
So for treatment of hirsutism, you can use certain diuretics that will also decrease your sex hormone globulin, or sorry, can decrease your androgen. You can use topical, the efflurin.
So you said a diuretic?
I believe so. I'm blanking on it.
Do you know the name of the diuretic? Okay, so continue. You said some topical?
Oh, spironolactone. You can use spironolactone.
Can you tell me the exact mechanism of action for that?
So spironolactone decreases, it decreases the circulating amount of androgens.
Anything else? And how specifically does it do that?
I'll have to review this, sorry.
No worries, no worries. In what time frame would you see maximum benefit if you were to start a medication for the treatment of hirsutism?
So maximum benefit in order for hirsutism is between 8 and 12 weeks, about 3 months.
So let's say a patient presents to you with complaints of hirsutism. What would be in your differential?
So when a patient presents with hirsutism, my differential would include polycystic ovarian syndrome. It would include a either Sertoli-Leydig or a testosterone secreting tumor. Depending on the age, it may include a chromosomal or metabolic pathway abnormality.
What do you mean by chromosomal?
So if there was a defect in 5-alpha reductase and they were actually, if it was a younger individual and they ended up actually being male as opposed to female. I would also, on my differential, I'd also include exogenous testosterone use or exogenous hormone use.
Anything else?
I think that's what I'd start with.
How would you evaluate the patient to try and narrow down that differential?
So I first would take a detailed history and physical. So I'd find out when they first started noticing the hair growth, if it was associated with any other symptoms such as menstrual abnormalities. I would get a detailed menstrual history. On physical exam, I would do a pelvic examination, and I would consider also ordering a transvaginal ultrasound. When I was doing my physical exam, I'd look for the hair pattern, and I would order a testosterone level if it was a significant amount of hair.
Any particular in your exam you're looking for that would make you concerned of an androgen secreting tumor?
If I could feel an adnexal mass
Okay.
on palpation.
And the ultrasound will help you in what way?
If I can see a adnexal mass, also take a look at the uterine lining.
What would the uterine lining help you with?
So if it was extremely thin or if it was extremely thick, it could give me an insight to what their hormone status is.
In what way?
So if they are having irregular bleeding and they have a thickened lining, they could be having anovulatory cycles.
Okay.
That's something
see
I
your
would keep
point.
on my differential.
Okay. All righty. Any other than the ultrasound, any specific lab work you would do?
I would order a serum testosterone. Everyone says pregnancy test, so I would consider doing a pregnancy test, make sure. I would start with those two.
Anything else?
Depending on their age, you could also consider looking at an FSH and an LH to see if they are ovulating.
How would that tell you they're ovulating, the FSH, LH?
If you're looking at, depending what day you ordered your lab, to see if they're having the appropriate rise or if they have an extremely elevated FSH at a young age.
You're trying to evaluate to see if the patient ovulated? You're saying an FSH is a good test for that?
It's not if they are in the perimenopausal, but if they're a younger patient, you can see that for early.
You're sure about that?
It is my understanding that an FSH is not useful if you're in the perimenopausal to menopausal.
To tell you if you ovulated?
To tell you if you're going into menopause, so you're no longer ovulating.
You said I know that, but you said you would assess to see if the patient was ovulating. That's what I understood.
If you're looking at, part of the differential, if you're looking at the PCOS with having irregular cycles.
That would tell you if you're ovulating or not? The FSH? I'm confused.
I think I just confused myself, so I'm going to just take off the FSH knowledge.
Now, do you know if there's a test and it's not an FSH that assists in telling you if the patient ovulated or not.
We can look at an LH surge. That's the most, that will tell you when
And
you,
how would you do that?
you can have them do self-test at home.
What would you do in the lab? Something you can order, doctor.
Within an LH. You can look at their progesterone.
When would you do that?
If it's less than 5, then
When would you draw it?
it would have to be in the luteal phase. So that's about 14 days before their expected onset of menses.
So in the cycle day number what?
Like 21.
Exactly. FSH, I'm gonna get out of examiner mode. FSH doesn't, I mean, it could tell you if somebody's menopausal. It could help with like precocious puberty, if somebody has primary amenorrhea, but it really does, it's a difficult test to really assess if somebody ovulated. It's more a 21-day, the ovulation kits are the best, you know, because you can do it at home and whatever, but if you had to order something, it's a 21-day progesterone and a 28-day cycle. Okay.
Okay.
Any other tests that you would order?
Not at this time.
What if I told you she had non-classical congenital adrenal hyperplasia? What would you order? So that can lead to hirsutism, right?
Yeah. So for non-classical congenital adrenal hyperplasia, I'd want to order a cortisol, I believe. I want to check her blood pressure. And 11. I'd have to relook
If I
at
told
that.
you it's a 17
I was going to say it's a
hydroxyprogesterone.
17 something, but I couldn't remember the exact one. And
There
it was
you have it
17,
there.
13, and 11, but I can't remember the exact ones with those.
So growth phase of hair, anagen, primary growth phase, the majority time hair spends, catagen, hair follicle involutes, telegen, resting phase that lasts several months, and hair sheds at this stage. Mechanism of action is spironolactone. It decreases ovarian adrenal production of androgens. It decreases dihydrotestosterone by inhibiting 5-alpha reductase. Usually maximum time frame for benefit is 6 months. Okay. Now, realistically speaking, I think that 5-alpha reductase genetic, and which is very rare, I think you would figure out something's really wrong with the hirsutism because other things will be going on. You know what I'm saying?
Yeah.
Yeah, you had a good differential. Just didn't say the congenital adrenal hyperplasia, and that's perfectly fine. You can worry about Cushing syndrome. The cortisol is like you're trying to rule out some other cause, like than the congenital adrenal hyperplasia. Okay, you have Cushing's and those type of things. So any result of 17-hydroxyprogesterone greater than 200 should be confirmed by an ACTH stimulation test. Okay. Questions on that? Sorry if that was a tough one.
I just haven't looked
But
at that in a while.
you said you were an oncologist, so I won't give you something hard. Go ahead. I'm sorry. Because to me, all these like REI things are hard.
They
for
are
sure.
super hard. I
They are.
don't do a lot of REI, so
Yep. I know.
sorry if you can hear that.
Oh no, you're good. You're good. Questions? How did it feel?
I mean, I despite the fact I'm an oncologist, I never like speaking in public, so
Right.
not my favorite, and doesn't help that I have a colicky newborn. So
No, no worries. No worries. I thought you did well.
thank you.
All right. Very good. All right, Charlotte. I know we're past time, but we can get a couple more people in, I hope. Charlotte, you're there?
Yep.
All right. Generalist, correct?
Yes.
All righty. Are you looking for anything specific?
Nope.
So pick the section you're looking for. Because I can't remember what we've done today at this point.
We could do office.
You want to do office? All right, let me think a second here. When would you start DEXA scans on a patient?
Age 65 in a postmenopausal woman without risk factors. Earlier in
What are
someone
risk?
with factors.
What are risk factors?
So tobacco use, family history, especially in the mother of fragility fracture, long-term steroid use. Yeah, those are some that come to mind.
And then what other, you said, is there a way to, I guess, evaluate mathematically if somebody should have a DEXA scan earlier?
Yes, so you can calculate a FRAC score, and if it's higher than 9% for a major osteoporotic fracture in the next 20 years, you could get a DEXA.
Now, how do you diagnose low bone mass?
Low bone mass would be less a T-score of less than -1. And osteoporosis would be a T-score less than -2.5.
Okay, so osteoporosis is -2.5. What's low bone mass?
Between -1.5 and -2.5.
Okay, I missed that part. Now, what's a Z-score?
So a Z-score is so it's comparing a patient's bone density to the average bone density of someone their age, and a T-score compares the patient's bone density to the bone density of a young individual with basically at an age where you'd expect peak bone density.
And in what situation would a Z-score be of any benefit?
I guess it would be most relevant in someone who is themselves young, like a patient who had amenorrhea and was at risk for bone loss for that reason, like related to, say, hypothalamic amenorrhea in an athlete or a patient with an eating disorder.
How would you treat osteoporosis?
So the main treatment for postmenopausal osteoporosis is bisphosphonate.
And what are contraindications?
Renal failure or any esophageal disorders like esophageal stricture or GERD.
And what's its mechanism of action?
It's anti-osteoclastic, so it would inhibit the breakdown of bone.
And how long would you treat for?
So I would treat initially for 2 years and reassess with the DEXA at 2 years.
And is there any recommendation on your calcium and vitamin D replacement?
Yes, so for postmenopausal women, the daily vitamin or the daily calcium intake is recommended to be 1,200 milligrams per day. For vitamin D, it's 600 international units per day for women between ages 50 and 69. And then for 70 and up, it goes up to 800 international units per day.
Alrighty. I think we should stop there. I think you did great. I can't think of
Thanks.
anything that you said that was wrong.
I think you may have asked me about osteoporosis back in August.
Before?
Actually.
No, really? What are the
I think,
chances of that?
yeah, I think it was 2 months ago though, so I've done
Really?
some studying since then.
I think you did good. It was good. Well, there you go. You learned. Did you do worse last time?
Oh
I know I
yeah,
picked you before, but I can't remember what we talked about.
yeah,
You know.
definitely worse.
Okay, awesome. Fantastic. Well, good on you. All right, other questions? No, I can't think of anything you said out of turn or anything like that. So good job, Charlie. All righty. Anybody else want to be on the hot seat? This will be the last individual. Let's see here. I just want to make sure nobody has any questions. Hold on, let me check on that. Alexandria, you're correct. The frax is 8.4% according to the new way they do practice bulletins, but some people have, like, I think up to date may say 9%. So if you're between that range, I think you'd be okay. But you are correct. The practice bulletin, or the equivalent of practice bulletin, is 8.4%. Z-score, you're matching people, Maya, who are of the same age as the person. T-score is with a young, healthy population, usually less than 30, to my understanding. So let's say you have a gal who has anorexia, definitely in those type of patients, they should be having a DEXA scan. And that way you can compare that patient to patients in their same age group. Does that make sense, Maya? So that's the purpose of the Z-score. Not used much, but in some cases, you know, you got people with eating disorders and so on and so forth. It could be helpful because you're comparing. You want to compare them to their age, you know, because a lot of those young girls are, 17 or whatever, much younger. Not that I've ever looked exactly if they to what age the Z-score can go to, because I'm sure there's a book that tells you all that, or you could look it up on the internet if that makes any sense. If you're talking about if she is anorexic, Maya, that's a tough one. That would be, I think, beyond the scope of OB. I think you if it's significantly different, it's showing that this patient is having issues with I'm assuming hopefully low bone mass or osteopenia. So I would definitely refer her to a specialist because they can do best. I think the simplest way to treat that patient, this is my opinion, is to give them the birth control pill, because you're giving them the estrogen and you're replacing that in essence. Can you do a frax? If you look it up on the internet, the frax score is very specific. The age is included. You can make up a patient that's young and see what it shows up, but I'm thinking you gotta be older. But you'd have to double check that, Maya. I don't know off the top of my head. Okay. Yeah, but I believe the age, they ask you that, and then you could. But I know when they're young and anorexic patient, for example, the Z-score is more important. Okay. All righty. See if we can get one more person on the hot seat here. I'm just trying to look down the line here. Gabrielle, I'm going in your direction. It says you're self-muted. It still says you're self-muted. There you are. Can you hear me?
Hello?
Can you hear me? Gabrielle, you there?
Huh.
Can you hear me? Hello?
I hear you. Let's see.
Can you hear me? Hello? All right, I've lost her. All right, see if we can pick somebody else. I'm sorry for Gabrielle.
Hello?
You're there? Is this Gabrielle? Can you hear me? Are you there, Gabrielle? Ruby, I'm going in your direction. Are you there? You there, Ruby?
Yes, I'm here.
Can you hear me? I don't know, we're having
Yes,
technical
I can hear you.
difficulties here. All right, cool. You're a generalist, correct?
Yes, ma'am.
Awesome. What are you looking for? You need a specific case on your list or a topic? What you looking for?
No, you can choose.
All righty. Let's do a GYN case. Okay.
All right.
Can you tell me in gynecology what particular nerves can be injured? And it could be any type of hysterectomy while you're doing a hysterectomy, for example. An abdominal hysterectomy, vaginal hysterectomy, TLH, LVH. Well, I'm giving you free reign. You can name me several nerves and how the injury could have occurred and how it presents.
Okay. So during when you're making a initial fannestial incision, you can injure the iliohypogastric nerve and the ileoinguinal nerve. And the way they present is loss of sensation for the iliohypogastric, mostly on the like the mons and labia majora, and then the ileoinguinal is mostly loss of sensation at the labia majora. You can also injure the femoral nerve. This typically occurs during either hyperflexion of the hips during dorsal lithotomy, or placement of like a Bookwalter retractor. And that also presents with both a sensory and a motor loss. So sensory and the sensory loss of the anterior and medial location of thighs, and then the they're unable to walk. You can also injure the lateral peroneal nerve. That occurs also kind of during hyperflexion of the knees. And you would present with a foot drop. Let's
Any
see.
other nerves?
I think maybe during vaginal, you could injure, I don't know how, but you could injure the pudendal nerves. Oh wait, you can injure the obturator nerve. You can injure the obturator nerve, and that presents as difficulty at adducting.
And that's during a TBH?
No, not during the TBH. No.
Okay, just in general.
No,
Just in general.
yes.
Gotcha.
Correct.
Let me ask you, can you name me a procedure where the pudendal could be injured?
Maybe during like a what is it, sacrospinous ligament suspension, one of the urogyne procedure. Yeah.
Yep. And how would that patient present?
Would it be like butt pain? That's all I can think of.
Any other nerves?
You could potentially injure the sciatic nerve, but that's usually during like working deep in the pelvis, like a gynec case. And that would present as also kind of inability to walk. You're unable to extend lift up the knees. So difficulty walking.
Okay. Anything else?
That's all I know.
I thought you did very well.
Thank
I
you.
know
I literally just read this yesterday.
Well, good for you, because I would have failed that on the exam 100%. And I have a feeling on this exam, they're going to ask some question in regards to nerve injury. I have a bad feeling. I know I did in my exam. So hopefully they pick the nerves you know. No, that was very, very, very nice. Very, very, very nice. So I'm just going to go over some things. Okay. Is that cool?
Yes, please.
All right. So the incidence of nerve injury following pelvic surgery is approximately 2%. Neuropathies associated with pelvic surgery are more often due to the position of the patient or retractor blades than to direct operative injury. The prevalence of postoperative neuropathy depends on a number of factors, including the type of surgical procedure, the surgical approach, patient position, and length of surgery. The lithotomy position may result in sciatic, femoral, and peroneal neuropathies. Okay. The risk of nerve injury or the development of a compartment syndrome increases when patients are in the lithotomy position for more than 4 hours. This is according to UpToDate. For procedures extending beyond 4 hours, the surgical team should consider repositioning the patient into a supine position for 20 to 30 minutes to try and avoid these complications. The patient can be placed back in the lithotomy position if necessary. So the peroneal nerve, also called the common fibular nerve, it is at risk for injury from compression at the level of the fibular head. Thus, the lateral lower leg should be padded when stirrups are used. It clinically presents as foot drop or difficulty dorsiflexing the foot. Femoral nerve, usually injured by deep pelvic surgery, especially in abdominal hysterectomy. Mechanism is compression of the femoral nerve against the pelvic sidewall as the nerve emerges from the border of the psoas muscle prior to exiting the pelvis at the inguinal ligament. Compression is caused by deep or lateral placement of the retractor blades. Additionally, it could be injured due to prolonged compression under the inguinal ligament from positioning in the lithotomy position. May result in a weakness of hip flexion and knee extension, impeding the ability to climb stairs. Knee jerk reflex is absent. Sensory numbness over the anterior medial thigh and medial calf. So to my understanding, femoral nerve could be injured in either an abdominal hysterectomy or in the lithotomy position. So, TBH, LABH, TLH, whatever the case may be. Okay. So lateral, femoral, cutaneous, and obturator nerve injuries have been associated with lithotomy positioning by an unclear mechanism. Hip flexion beyond 90 degrees has been shown to stretch the inguinal ligaments, and since the lateral, femoral, cutaneous, and obturator nerves pass directly through these ligaments, this extreme angle should be avoided. The lateral cutaneous nerve of the thigh is a sensory nerve. It supplies the skin on the lateral outer part of the thigh. The obturator nerve is responsible for the sensory innervation of the skin of the medial aspect of the thigh. The nerve is also responsible for the motor innervation of the adductor muscle of the lower limb, external obturator, adductor longus, adductor brevis, adductor magnus, and the pectineus. It is notably not responsible for the innervation of the obturator internus, despite the similarity in its name. It can be injured, also be injured with the passage of the trocar during a TOT, for example. Numbness of the inner thigh and minor ambulatory problems would be noted due to weakened adduction of the thigh. The pudendal could be injured during an SSF or other pelvic reconstructive procedures when sutures are placed in the arcus tendinous fascia. It mainly leads to a sensory function of the perineum. It has no motor function. Symptoms include perineal and vulvar pain, which worsens in a seating position. Sciatic nerve. The sciatic nerve can be stretched at the level of the hip or knee, or may be compressed distally in the popliteal fossa. The degree of hip flexion or abduction or knee extension that may cause sciatic nerve injury has not been determined. As a general rule, the position of the hips and knees during anesthesia should be limited to those that are comfortable preoperatively. Okay. If you do, to my understanding, if you did an SSF and the patient is complaining of severe butt pain in the recovery room, you have to go back to the operating room because you, with the suture, grabbed the sciatic nerve and you bagged it. Okay. The ileoinguinal and genitofemeroal can be directly ligated via fannestial incision and suture closing of either a laparotomy or laparoscopic incisions in the lower quadrants. Both these nerves are at risk of compression from lateral retractor blades. The genitofemeroal is most at risk during sidewall dissection during external iliac lymph node dissection. The nerve lies quite lateral. Ileoinguinal injury causes sharp burning, lancetating pain radiating from the incision to the suprapubic area and the labia, and the genitofemeroal injury causes paresthesias of the labia and upper medial thigh without motor deficits. Okay, so very nice, Ruby. Any questions?
No, this was good.
I
Thank
could
you.
never have done this. Go good on you. Very good.
Thank you.
All righty, very good. All righty, guys. If anybody has any questions about anything that we talked about, please put it in the box because we're going to be winding down here. I know on the last webinar that I had, somebody had brought up the they brought up how much vasopressin to use. So I found this in Up to Date, and I'm actually getting it from the Up to Date article. So hopefully you could see that. And it's I believe it's in the section or the article that discusses how to decrease bleeding in a myomectomy. And it says here, in the practice of the individuals who did the article, they dilute 20 units of vasopressin in 100 cc's of saline. So 4 to 6 units of vasopressin equals 20 to 30 cc's of the solution. So, because they had asked, and I thought I had read before 10 to 20 units of vasopressin in 100 cc's. So that's straight from Up to Date. I know the individual had typed the question, had said something about 4 to 6 units of vasopressin. Don't quite sure. I remember what they had put in the question box, but there's a dilution. And of course, there's many different ways of diluting things, but that, that's what they do in their practice, the individuals who did this article. Okay. I wish I can get the title. I'm trying to see if I can get up to there. Techniques to reduce blood loss during abdominal or laparoscopic myomectomy. Updated in May 2022. September 22, current literature. Okay. Alrighty, so does anybody have any questions before I let everybody go? I hope it made sense in regards to all the topics that we talked about today, because we want to get, even though people are talking about, some people have, they like to discuss their case or topics. Hey, it's everything's game, because anything can be asked on this exam, as you well know. So I'm going to see if anybody else has any questions. If you could put them in the question box, because at this point I can't tell who has their hands up or not. I can try and lower them, but they kind of come back up. So if anybody has any questions, Just raise your hands. I think everybody that participated today did a great job. It's really tough to be on the hot seat. I know some people are getting their exams next week. Some people still have that reprieve to November, and I'm sure we're getting people calling in for December. So I recommend everybody get on the hot seat. I mean, it really helps you kind of sort things out in your mind to be having that additional pressure than just sitting at home thinking, I would do this, this, and that. It's different if you're talking about it. So if I'm seeing here, nobody's putting any other questions in the question box, so hopefully everything made sense. I try to stay as current as possible. Let me see. Oh, I got a couple of things here. Okay, so I got an off topic here, but let me just, Ruby, give me 2 seconds. Let me go back and make sure I didn't miss anything. All righty. Okay, well, good luck, Jacqueline. Okay, appreciate it. Good luck, okay? So Ruby, off topic. Okay, ulipristal plan B. The thought process is it inhibits or delays ovulation for both ulipristal and plan B. Okay, remember, ulipristal is 120 hours or 5 days. Plan B is 72 hours, 3 days. Off-label use is the 5 days. Okay, so if somebody comes in 4 days, you say ulipristal has the better. I'm taking off the table the IUD, of course. And to my understanding, the Paragard is the only one, the copper, that is for emergency contraception. Miranda, I know studies have shown, but I don't think it's FDA approved for that. Have not seen it in their package insert. You know, they'd be selling it like hotcakes if it was. Okay. Oh, really? That's what Up to Date said, Ruby. So yeah, you got me on that. They believe that's the main mechanism of action, because they preface that they're not 100% sure, but their thought process, that's what happens. What did the person tell you? Well, you know, I know I gotta be honest with you. I know you're using the progesterone, and I know with Depo, Nexplanon, it does that. But for example, for the Nexplanon and the Depo, the main mechanism of action is inhibition of ovulation, right? So it's true, but I believe, according to this Up to Date, main mechanism of action they believe is that. So, you know, I would stick with that, Ruby. I would stick with that, okay? If we listed rotational maneuvers prior to delivery of posterior arm on our case list, how should we approach this on our case list? Nothing wrong. There's nothing wrong, because when I trained and when I took this exam, the rotational maneuvers were recommended before the posterior arm. Now I know that's changed. It's now posterior arm. The end here is whatever's going to work. Okay, so I think what's going to be key on this exam is all your different options. You do your McRoberts, your suprapubic, you do your rotational if you want to do that first. Usually they recommend now, this is the newer recommendation of the literature, but never say literatures, of the posterior arm. You can do your rotational. That doesn't work. You want to do your clavicular fracture. Keep doing your maneuvers as well. But yeah, I would not ding you for it as long as you get that resolved and the baby delivers. I think that's what's important. So I would not, Christine, worry about that. Okay. I mean, because it's a gestalt, whatever it's going to work, you know. Now, let's put it this way. If you went from McRoberts and suprapubic to clavicular fracture, then we missed some steps. You see what I'm saying? So I wouldn't fault you. I wouldn't fault you. Okay. So hopefully that helps you there, Christine. Okay. Any other questions before I let everybody off the call? Again, thank you for everybody who participated. Everybody I thought did a great job. Again, hard to be on the hot seat. And the more you're on the hot seat, the more you verbalize your thought process, the better you get at it, and you're better to edit, and you won't say like things you shouldn't be saying, and you're like, oh, I shouldn't have said that because I don't want to discuss that. Okay. So what I'm going to do is I'm going to stay on the line. I'm going to leave the question box open, And if anybody has any other questions or concerns about anything, I'll type it in because I can send it to you privately. Also, any ways we can improve our webinars. We're always seeking to do better. An example, I think we all try our best as faculty to be up to date and abreast on everything. Things do change, and I learned doing these things as well. So keeps me current as well. So I really, again, appreciate everybody that participated. I know for some of you guys, next week is the day of taking the exam. I wish you all the best of luck. Stay focused because it's just around the corner. Make sure all your tech is working okay, because that's very important. You've done your tech checks. Also, please follow the directions of the examiners. If they tell you to keep the phone out of the room, do not bring your phone in, okay? Please, they run the show. They can nullify your exam score after you're done with the exam, because that happened last year. Somebody brought their phone in the room, they finished the exam, and they were notified by the board several days later that they were voided. Their exam score was voided. So please follow to a T what they want from you, okay? So at this point, I'm gonna let everybody off the call. I'm gonna stay on. If anybody has any questions, we can do a private chat if you need it. Again, if we can improve how we do this, also please include that. And I wish everybody a good night and a good rest of the week. And those taking the exam next week, good luck, okay? Good night.